And here is your question.
Okay, ma'am.
Right. So if you have read and understood, considering it history taking station, kindly begin.
Okay. Wash my hand. Hello, I am Mohammed Al-Ayan, one of the exam candidate. May I confirm your name and age, please?
I'm Tom, 64 years old.
Good.
Nice to meet you, Mr. Jones. Today I have been asked to ask you a few questions regarding your condition. Are you okay with this?
Okay.
How can I help you today?
Doctor, I've been having this tummy pain, and then I've passed blood through my back passage while passing the stool, and I'm also having constipation.
I am sorry to hear that. Which start first, bleeding or pain in your tummy or constipation?
Bleeding. I had bleeding initially.
I am sorry to hear that. Did it start suddenly or gradually?
It was gradual gradual.
Mm-hmm. When you first noted that this?
What, blood?
Is it my network or it's
Yeah. When you did
yeah.
first noted that the bleeding?
6 months back, I think.
I am sorry to hear that. The bleeding come and go or increase or progressive?
It comes and goes, and yes, it is increasing with days and months.
Mm-hmm. What is the color of the blood?
It's red.
Mm-hmm. How much blood do you need every time, like streaks or teaspoon or more?
It's not too much. It's like scanty, small amounts.
Mm-hmm. I'm sorry to hear that. The bleeding is painful when you pass the stool?
No, doctor, not painful.
Mm-hmm. Anything that the bleeding stop or increase?
No, doctor, I didn't notice that.
Mm-hmm. Do you have any what?
Any what, doctor?
Do you have any disturbance regarding the bowel habit,
Network.
Bowel habit?
Change in bowel habits, I think is
Oh, okay.
the network
Yes,
is really
yes,
bad.
doctor.
Yeah, do you have disturbance regarding the bowel habit?
Yes, doctor, sometimes.
How do you
I am sorry to that.
Sometimes.
Your appetite.
Since last month, I have been not able to eat. My appetite is really low. I think we lost him.
Yeah, I think so as well. He's there, but network is really bad.
Hello? Hello?
Yes, please.
Hello?
Yes.
Hello, yes.
Have you noted intentional weight loss? Have you noted any intentional weight loss?
Any intentional?
Yeah, unintentional weight loss.
Yes, I think I have lost weight, and because all my clothes are loose now. Yes, doctor.
How many kilo over how long?
Around 10 pounds in last few weeks.
I am sorry to hear that. Have you noted any bleeding from other orifices?
No, no, doctor.
Noted any itching or
I didn't get you, doctor.
Any itching or
Oh, no, no,
that-
doctor, no. I didn't notice anything as such.
his network is really hopeless. I can hardly hear him.
Hello?
Yes. Continue, please. All right. Thank you. Can you present your case now?
I cannot hear, ma'am.
Yes. Can you present your history now?
Today I take history from Mr. Jones, 64 years old, presented with bleeding rectum since 6 months ago, start gradually with the pain in your tummy and with weight loss and approximately 10 kilogram lost in the last 3 months, and he has hypertension and a smoker from 35 years. My professional diagnosis could be cancer colon. Another differential diagnosis could be inflammatory bowel disease and diverticular disease, angiodysplasia, bilious fissures, and gastroenteritis.
How would you confirm your diagnosis?
Yeah, I would like to do examination, general examination, and abdominal examination, and I've done colonoscopy plus biopsy to examine the wall, the colon, and also need some laboratory investigation like full blood count, urine, and electrolyte, ultrasound, CT scan, and upper GIT endoscopy to exclude other the causes of the upper bleeding, and also need
Also need what? What is the possible management that you can suggest for this
stool
patient?
analysis.
Okay. What is the possible management that you can suggest for this patient?
The management, the management, the history and examination and investigation, and
Right.
after multidisciplinary meeting, the management according to the tumor infiltrate, according to the
Right. Network was very bad. I couldn't hear most of what you said.
yeah, bad, very bad, ma'am. I am sorry.
Yeah, that's all right. But then feedback, Dr. Mohammed. it was very good. It would have been good if we could have hear you properly and we could have appreciated that you have taken the complete history. But what I can understand, you have missed quite a lot. So when I asked you to present your case and you were telling me about the differential diagnosis, once you were presenting your case, if you would have said or if you would have mentioned all the points that you have missed while taking the history, that would have been good before you told me about the differential diagnosis, because differential diagnosis was the next question that I had to ask you. Right. And then, yeah, I understand you have a quite vast knowledge. So you answered me correctly about the investigations and confirmation and all that. But yeah, and one more request. In the beginning, when you wash your hands and you introduce yourself and you confirm patient's name and age, then jump to the next question. How can I help you today? Right. You asked, I've been asked to ask you a few questions. Is that all right with you? Omit that, because this is a history taking station and you don't have to take the consent in this one. If you ask more personal questions, then maybe, okay, you can ask, like in case of history of infertility or importance, then you, once you're asking those personal questions, then, but then this will save you a few seconds as well.
Yeah, ma'am, internet disconnected. I cannot hear the Dr. Karma.
Yeah, completely. And we couldn't hear you as well. We just guessed what question you were asking. But then what I said, that when you presented your history, if you would have mentioned all the points that you have missed or could not complete, that would have been better. Have you understood that?
Yeah.
Started, and here is your question. Right. So if you have read and understood, considering the critical care scenario, kindly tell me, how do you plan to manage this patient further?
Okay, I will manage according to the CRISP protocol using ABCD approach.
Yes.
Total airway if it's patent and breathing, check oxygen saturation. Patient might need high flow oxygen, and also I will check for ABG for the circulation. Patient is hypotensive, I will stop all fluid immediately.
Very good.
And give diuretic. Also, patient might need GTN, aminophylline. Then I will complete my ABCD approach. After that, I will do history and examination.
Yes.
I will do some investigations such as chest X-ray and ECG, and also I will do ABG.
If you look at the patient's fluid chart, it says that patient was given approximately crystalloids and colloids, approximately 7 liters. Kindly comment on it. Do you think it's enough, or?
This is too much fluid is given
All right.
for saline and 2 colloids.
So what is the provisional diagnosis that you suspect? What is patient suffering from?
This is most likely have pulmonary edema.
Okay. How should have been patient managed ideally, post-operatively?
Patient we need manage in intensive therapy unit.
What is the maintenance dose that should be given to the patient post-operatively of the fluid?
2 liters of normal saline.
Tell me please completely, under how long? 24 hours or under 6 hours, or please?
For 4 to 6 hours.
Okay. All right. Can you please tell me how would you manage a patient's symptoms? Patient has become hypertensive and tachycardic. What measure would you do for that?
Okay, I will stop our fluid, give aminophylline, and GPN, or also I will give fat morphine.
What is the function of GTN nitrites? What do they do on heart?
Vasodilator.
Yes.
Reducing the load. It is lowering the blood pressure.
So they reduces the preload. How afterload can be reduced? What measures can be taken to reduce the afterload?
Patient will need ACE inhibitors such as enalapril 1.25 milligram, or also captopril 25 milligram.
Okay. Despite the fact that patient was given 7 liters of fluid, patient is still oligouric. What do you understand by this term? How much urine per 24 hour is passed in order to be categorized as oligouric?
The normal is 0.5 to 1 milligram per kg per hour.
All right.
Due to physiological response to
Yes.
after 24 or to 36 hourly.
Yes.
Due to the release of glucocorticoid and mineral corticoid, which
Yes.
reduce water and sodium retention. It is also maybe due to after surgical trauma and some anesthetic gases, which lead to release of vasopressin, which lead also to retention of water and sodium.
Okay. Can you please tell me what is the daily requirement of sodium and potassium for a patient postoperatively?
Yes. For sodium, it is 1 to 2 milli equivalent per liter, and for potassium, it is 0.5 to 1 milli equivalent.
What measures can you suggest that can be done in order to prevent fluid overload in the future in this patient?
Okay, I will report this case to the hospital reporting system. Also, there will be better education to the junior staff. Also, I will set central venous pressure to monitor the pressure, and also urinary catheter, and also input and output chart.
Okay, how would you take care of sorry, okay, how would you take care of the do you think that patient is undergoing cardiogenic shock? How would you manage that if so?
This is patient in cardiogenic shock. Patient might need ventilator support on CPAP. Also, I will give some inotropic for dobutamine or dopamine, 5 to 10 milligram.
How frequently should a patient be monitored?
1 hourly.
Okay. Who would you involve in the management of this patient?
I will call my consultant, general surgeon, and the anesthetic consultant.
Can you name few conditions which increases the maintenance fluid requirement postoperatively?
Paralytic ileus, also an acute pancreatitis.
Okay.
And burn.
Burn, okay. All right. Can you tell me what are the factors which determine how much fluid should be given to a patient?
The central venous pressure and the heart rate.
Anything else?
And blood pressure.
All
and
right.
Urine output.
Yes, ongoing fluid loss. Okay. Right. Can you please tell me what is the composition of normal saline?
Contain saline 150 millimole per liter, and also chloride 165.
Yes. How would you compare that with ringer lactate or Hartmann solution?
Hartmann solution contains saline 131
Yes. And
contain potassium 111.
all right, can you tell me, please, what is the purpose of giving fluid therapy? Why it was given on the first place?
Sorry.
What is the purpose of giving a fluid therapy? The
Uh,
purpose, yes.
to prevent hypovolemic shock.
Anything else? Okay,
And
this
to
you'll read.
avoid dehydration. Okay.
Can you please help me and read this image? What are you looking at?
Okay, this is just X-ray, most likely posterior anterior view.
Yes, showing what?
Uh,
A, B, C, D.
This is okay. The trachea it is shifted minimally to the right, and also suppose there is no discontinuity, and there's cardiomegaly, and there is absence of costophrenic angle on the left side.
What does that signify?
Most likely pleural effusion or
Yes.
pulmonary edema, and there is dilated upper lobe vessel,
Yes.
and there is bad signs. It's most likely the jet of pulmonary edema.
All right. Good. Okay. Started, and here is your question. Right. So if you have read and understood, considering its surgical and administration, kindly identify the structures. Can you identify what structure you're looking at?
It is the undersurface of the liver,
And
showing the gallbladder
yes,
and porta hepatis.
right. So can you please help me and identify 9, please?
9 is the gallbladder.
Yes. Can you please identify 25 over here?
25 is the right triangular ligament.
Okay. Where is it attached on the other side? What's the attachment of triangular ligament?
It is attached with the diaphragm, undersurface of diaphragm.
Okay, what is it 5? Yes. Yes, 5. Yes.
5
yeah.
is the hepatic duct.
Okay. What is 21?
21 is the quadrate lobe.
Okay. What is 17?
17 is the falciform ligament.
Okay. What's the function of falciform ligament?
Falciform ligament, it supports the liver
Yes.
with its attachment to the diaphragm and the anterior abdominal wall.
Okay.
And also,
Okay. Yes. Can you identify 15, please?
15, ma'am.
Yes. It's the left
15 is the
triangular ligament.
left triangular ligament.
Yes. Where is the other end attached?
It is attached with the diaphragm.
We'll
on
find
the
out.
surface
Okay,
of
can
the
you please tell me the surface marking of the gallbladder?
it is demarcated at the point joining the tip of right costal, the right ninth costal cartilage and the lateral border of rectus abdominis.
Rectus sheath. Okay, can you please tell
Rectus
me
sheath.
when there is cholecystitis, why does the patient feel pain on the tip of the shoulder?
Because the inflamed gallbladder will irritate the diaphragm, which the diaphragm is supplied by phrenic nerve, which also have common roots with the supraclavicular nerve supplying the shoulder tip.
Okay, can you please tell me all the parts of the gallbladder?
Gallbladder has mainly three parts: the fundus, body, and the neck.
Okay, what is the blood supply of the gallbladder? And you
It is
said
supplied
blood
by
supply.
It is supplied by cystic artery, a branch
And
of
drained by?
hepatic artery,
Yes,
and drained by cystic vein.
yes. All right, can you please tell me all the parts of the liver that you can see right now? How would you
This is
divide the
the
liver? Yes.
liver. It can be divided anatomically and surgically. Anatomically, into right and left lobe by anteriorly by the falciform ligament,
Yes.
inferiorly by ligamentum teres, and inferior posteriorly by the ligamentum venosum, and surgically by a line passing across the groove inferior vena cava and the fossa of gallbladder.
Okay, what are the vessels which supply the liver?
The liver is supplied major portion by portal vein and also the hepatic artery.
Hepatic artery is branch of which vessel?
Hepatic artery comes from the common hepatic, which is a branch of cystic artery, celiac trunk.
Where hepatic artery is located, or where does it run?
It runs in the right free margin of the lesser omentum.
Okay, what is porta hepatis? You talked a lot about porta hepatis. What is it?
Porta hepatis, it is a part of the liver on the undersurface where the important structures like the hepatic duct,
Can you
hepatic
tell me their
artery, and the
relation
porta.
in, yes, anterior to posterior, please?
From anterior to posterior, we have the common hepatic duct, then the hepatic artery and the portal vein.
Okay. Can you mention all the structures which support the liver?
The structures that support are falciform ligament attached to diaphragm and abdominal wall, lesser omentum to the stomach and first part of duodenum, the right and left triangular ligament to the diaphragm, and the upper and lower coronary ligament also to the diaphragm.
Okay, what are the coronary ligaments? Can you identify here in the diagram?
It is number 12.
Okay. Can you identify the image that you're looking at? What type of image is it? What are you looking at?
I'm not quite sure.
Would you be able to identify the structures marked A to E?
Is it the contrast image of the biliary tree, ma'am?
I'm asking, so you have to tell me. We'll discuss later.
E is the common bile duct.
Okay, and D?
D, I'm not sure.
Okay, anything else that you recognize? What is A, pointing at something?
A looks like the gallbladder.
Okay. And
B and C,
B?
the right and left hepatic duct.
Yes. Anything else? how this image can be taken, or what is the purpose of doing this imaging?
To see any obstruction in the pathway of the bile.
What are the
Mainly the
methods
hepatic.
that we can apply or we can use if there is an obstruction in the biliary tree therapeutically?
We can do ERCP
Yes.
and stenting.
All right. What is ERCP?
It's
Why ERCP is
endoscopy.
better than MRCP?
ERCP, it has a therapeutic role. That's why it is better than the MRCP. We can do the stenting and also, if possible, removal of the stone or any
Okay.
obstruction.
Thank you, Bella. So what kind of, can anyone else tell what kind of image is this that we are looking at?
An intraoperative cholangiogram.
Yeah.
Magnetic resonance cholangiopancreatography, MRCP.
Okay, thank you.
And any guess on the structures?
I think A is the gallbladder.
Okay, and
E is the common bile duct. Then the cystic and the common hepatic. B is cystic, C is common hepatic.
I'll tell you right now. Right. A is gallbladder, correct?
Yes, yes, ma'am.
Even Dr. Karma told. B is the right hepatic.
Okay.
How to turn off this Chrome adjustment? Okay, right hepatic duct is B. C is left hepatic duct. D is right renal pelvis. See, it's below. If this is gallbladder, this is so below. So this is right renal pelvis, makes sense. Then E is common bile duct.
Yes, yes.
So that you had correct. Very good.
Thank you.
So next time you'll tell me the difference in ERCP and MRCP. Here is your question.
I'm not seeing the question yet.
How come?
It's unknown.
Yes.
Yeah.
Right. So if you have read and understood, considering the communication skills station, kindly begin.
Hello, madam. Good afternoon. I am Dr. George, one of the surgical doctors here. Please, may I confirm your name and your relationship to the patient?
My name is Betty. I'm Abigail's mom.
Okay.
Yes, doctor.
All right.
I'm so worried about my daughter. Oh my God, I was just coming back from work and they told me my daughter's been admitted for surgery. What's wrong with my daughter, doctor?
It's okay, ma'am. I'll tell you all that is wrong with your daughter. But first, you need to be calm so that we can talk effectively. Your daughter was brought in this afternoon by her teacher from school. She complained of tummy pain from our initial evaluation investigation. We think she has acute appendicitis. The signs, the complaint she came with and our examinations are highly suggestive of acute appendicitis. She has been on fluids. She has been on intravenous fluids, and also antibiotics. But currently, we are waiting for our consultants who will come in to operate on her.
Oh my God, doctor. Oh, I feel so bad. I feel like I abandoned my daughter. This is, oh my God. Doctor, are you sure my daughter has acute appendicitis?
All right, Mrs. Betty, you don't have to feel so bad or blame yourself so much. This could actually happen. Acute appendicitis is a common condition. Like I said earlier, from the complaints your daughter came with, the tummy pain and the examination findings we've had and other investigations, it's highly suggestive that she has acute appendicitis. But we cannot say these, we can't say this perfect 100% until we open up and see what's really happening in there.
Okay, doctor. Is it dangerous? Is my daughter going to leave? Is it bad?
Well, acute appendicitis is a condition that, if left, it could become very dangerous because the appendix itself is like a tube, and it could rupture. When it ruptures or perforates, it could release some dangerous contents into the tummy, and that could be very dangerous for the patient. That is why we are doing all we can as much as possible to operate on her early, so that we can save her life.
Will the wound be ugly? You know, my daughter, I want my daughter to be a model where she grows up, you know. Will the wound be so bad? You said we were going to operate on her.
Well, with a small transverse wound, it will just be a small scar. But in some cases, we may need to have a proper access to see what's really happening in the tummy. So we may need to extend the wound a bit. If that happens, there may be there may be some large scar.
Okay, don't you have any other option? Do you have to give her a scar?
Well, there is another option of doing a surgery where we can put in some cameras into her tummy and take out the appendix. But the plan for her current surgery is to do the one where we have to open up.
Okay, doctor. Is there any other problem that could occur to my daughter?
Well, yes. Like I told you earlier, if the appendix is not operated on early and it doesn't resolve and ruptures, the infection around there could actually affect some other structures around there, like the reproductive tube of your daughter, which is around that area. That's on the right side. It could become blocked, and this may affect her fertility in future.
Oh my God, doctor. So you mean she can't have kids?
Oh, no, not at all. That is not exactly what I'm saying. Your daughter may not even have that at the moment, but in the instance where that happens, every female has two of such reproductive tubes. So the left side should still be effective for her to have children.
Oh, that's relieving, doctor. What's the name of your consultant again?
Oh, the name of my consultant is Mr. Ladd.
And
oh my God, be here
Mr. Ladd. Mr. Ladd
Yes.
was the same person who operated my dad. And my dad died after the surgery. Oh my God, I don't want this Mr. Ladd to do my daughter's surgery.
Oh.
Can I get another surgeon to take care of my daughter?
I'm sorry to hear about your dad. Mr. Ladd is actually one of the good hands we have around here. But if you don't mind, can you really tell me what really happened? How and when did your dad die?
Oh, my dad had cancer of the colon, and he was operated. And a few days after the surgery by Mr. Mann, my dad died. So really, I don't want him to touch my daughter. It's really something that's worrisome for me.
Sorry.
Can't you do something about that?
Sorry to hear that, Mrs. Betty. But like I said earlier, okay, your dad actually had a cancer of the colon. Cancer on its own, it's a terminal illness. Your dad could actually have died from the effects of that. I can assure you, Mr. Ladd is a very good surgeon, one of our best around here, and I think he should be able to handle your daughter's case effectively. You don't have to be worried about that.
Okay, can I see my daughter, please?
Yes, please, you can. You can. I'll take you to see her shortly. But in the meantime, if you do not have any other queries, I would like to summarize all what I've told you. Your daughter was brought in this afternoon by her school teacher from school, complaining of tummy pains. Following our initial assessment of her, that's listening to her and examining her, we think she has acute appendicitis, and we are preparing her for a surgery this afternoon. Do you understand all that, Mrs.
Yeah,
Betty?
I understand all you've said, Doctor.
All right. If you don't mind, I'll take you to see her now. Thank you.
Okay, okay.
You still had 1 minute.
So what will I do if you have any other questions? Who am I going to talk to?
Okay. We would still be here to assist you if you need anything. I will drop my number with the nurses. If you have any question, please feel free to reach me at any time. We'll be here to help you.
Oh, great. That's great. Thank you, Doctor.
You're welcome, Mrs. Betty.
Still 40 seconds. Okay.
Yeah.
All right. I'll let that go. Yes, it was good. Did you, by any chance, explain what appendicitis is?
No, he did.
No, he didn't.
No, I didn't.
That was something you were supposed to explain, because some
Okay.
people may not understand appendicitis, but you can say that is an organ which is, yeah, it's all right if you can remove it and information of that organ and all that. So there,
Okay.
this 40 seconds would have been enough. Now 5. All right, good. Otherwise, it seemed to be a very good communication between you two. Good.
Okay.
Yes, Dr. Question. Can you see the question now?
Hello, ma'am.
Yes, can you see the question?
Yes, I can, ma'am.
Good. Right. If you have read and understood, considering its communication skill station, kindly begin.
Yes, ma'am. Good evening, sir. My
Good
name is
evening.
Dr. Abbas. I'm SHO with Mr. Smith's team. I've been asked to discuss with you about your the operation. Can I confirm your name and age, please?
Okay, I'm Mr. John, and I am 65 years old.
Oh, great, Mr. John. Can I call you John?
Yes, please.
All right, John. John, you are scheduled for a surgery in a week's time, 5 days time, and my Mr. Smith has asked me to discuss with you about the need for you to stop your warfarin. That's the drug you take, your blood thinner, the one daily, orally. About the need for you to stop it before your surgery, which we'll be doing in 5 days. I was told that you're concerned about the drugs. I would like to know your concerns.
Yes, my major concern is when I started taking the drugs. I remember my GP telling me then I should not stop the drug for any reason, that stopping it would threaten my life. And that is why I'm very concerned.
Oh, miss. Sorry about that, John. You know, actually, the warfarin tablets are actually, yes, meant to help your life, keep you, prevent blood clots from forming all over the prosthetic valves that you've had. And these tablets are taken orally, but there are other drugs that we'll be giving you over the next 5 days, and the reason why you have the warfarin is because it's an oral formulation. You can take it by yourself. You don't need any medical personnel to give it to you. And then also it's easy to administer. But the problem with the warfarin is that it has a long action. It will take about 5 days, and for its action spends about 5 days in your body. So we will over the next 5 days, we'll be keeping you in the hospital, and then we'll be changing to another drug which also has the same effect as warfarin. It's called heparin. Heparin will be given to you, and it will be administered through your veins. And then it gives you the same effect. It's also a blood thinner, and then it will be given over the next 5 days. It has an action of just 12 hours. Do you have any?
Yeah. Did you say heparin?
Yes, the name of the drug is heparin.
It's heparin. Oh, okay. I haven't really known so much about this heparin. Though you've said some things. Can you tell me more about it? Why use the heparin?
Oh yes. Because as I said earlier, Mr. John, heparin is also a blood thinner like warfarin, and it acts by also helps prevent blood from forming over your prosthetic valves, just like warfarin you were given. Also, it acts for us. That's meaning it has a shorter time it acts in your body, so that when we will be taking you to the theater, we can easily stop it 12 hours before your surgery. You would not be at risk of bleeding. We would also be monitoring the level of your the ability of your blood to clot, to watch how in order to monitor you, to prevent you from having any blood clots or having any problems after we commence this drug.
Okay, but is it? I think I heard you say I'll have to stay in the hospital. Is it really necessary for me to stay in the hospital before the operation?
Oh yes. Oh yes, Mr. John. Before the operation, 5 days before the operation, when we stop the warfarin, you will be in the hospital, because the heparin is given through your veins. So of course, you would not be able to give that to yourself, and also because we need to monitor your blood, ability of your blood to form clots, and take your samples, and also monitor your state and examine you while you're on admission.
Oh, it said it's going to be given through my veins. Is
Yes.
there no other way it can be given? Must it be through my veins?
Oh yes, preferably the heparin will be administered intravenous, but though there are other better drugs that can be given in a subcutaneous, given through your skin into the subcutaneous tissue, into the fat in your skin. Yes, but they will be giving you intravenous heparin.
Okay, doctor. But when can I resume my warfarin? I think I really need the warfarin.
Yes, Mr. John. You after your surgery, we will we'll check your blood to see how your blood is, and see how the clotting capacity of your blood, and then we'll commence the heparin, and we'll be monitoring you. Well, we notice that while you're still having we'll commence the warfarin while you're still having. We'll start giving you the warfarin while you're still having your heparin, and then we'll monitor the level of your blood. The ability of your blood to clot, which is called the clotting profile, and then we'll do that. And when we see that your blood has attained the adequate level at which it can maintain, it will be that is appropriate for your prosthetic valves, then we'll stop the heparin, and then you can go home with
but there's this other medicine I have to take for my anxiety. I usually shake sometimes, so my GP had given me some medications for that. Do I have to stop that to stop taking it?
Is it the diazepam?
Yes, the diazepam.
Actually, take the morning of your just a sip of water at least about 4 hours before your surgery, so that it will help to relieve the anxiety of surgery.
Okay.
Yeah.
Okay. Thank you, doctor.
Thank you, Mr. John. Do you have any questions for me? Any other question?
Is there anything I need to worry about the heparin?
Oh yes, they have blood thinners. You can have or there's also what they call it can also cause thrombus formation, but this is not very common. It's not very common. But we will observe you and ensure that we monitor you fully, and then whenever we notice any problem, we would treat you appropriately, and or then we convert to an analog that would another drug that would serve similar functions. So you don't have to worry.
Okay, thank you, doctor. I think I'm fine with that.
All right, so I would like to summarize that I've discussed with you about the need for us to convert you to heparin from warfarin, and then you've understood the reason why we need to do the conversion, and then you also understand the risk associated with the administration, and then what's our plans for you after your surgery. Do you have do you understand?
Yes, I do.
All right, thank you very much, Mr. John.
At the end,
and have a nice evening.
Thank you, Dr.
Very good. At the end, patient will just talk about its apprehension about the surgery, inguinal hernia, and doctor will just explain, since it's recurrent, that's why it's important to be operated on. Otherwise,
Yes,
it was
ma'am.
very
Okay.
good. Yeah, good. You both covered everything, so